Well, hello everyone. Welcome. I think I'm gonna give folks a few moments here to settle in, to make sure that everyone has had the opportunity to join us, and we will begin shortly. Once again, welcome everyone. I think I'm gonna give it a few more moments here to allow people to settle in, to give folks the opportunity to join us, and we'll begin shortly. All right, let's go ahead and get started. It's 2:31 right now. I think there's still more folks joining us, but we can go ahead and get started. So my name is Clement Nisia, Director with National Council for Mental Wellbeing and the Project Director for the Certified Community Behavioral Health Clinics Expansion CCBHCE, National Trainer and Technical Assistance. And once again, thank you so much for joining us this afternoon. So to get started, I think it's important to re-emphasize that today we have SAMHSA's Peggy O'Brien and Sheeta Palacote joining us today to provide a presentation on the clinic collected required measures. And once again, we thank you for taking this afternoon to join us to learn more about the updated technical specifications for the behavioral health clinic quality measures that will be used by all CCBHCs as part of their CCBHC implementation effort. As I said, today we are joined by Peggy O'Brien and Sheeta Palacote, who will be covering the following measures as it pertains to time to services, social drivers of health and unhealthy alcohol use as it pertains to screening for brief counseling. Next slide, please. So a few logistics and housekeeping information before I turn over to, today's conversation to Peggy. Please note that this webinar is being recorded with closed captioning, and the recording will be made available and posted on the SAMHSA CCBHC website in roughly about a week. We ask that you mute your lines if you have any questions that you would like to ask the participants. There's a Q&A platform at the bottom of the Zoom platform, along with the chat section as well. So you can please go ahead and send us your questions as it pertains to today's conversation. Next slide, please. So please note that today's webinar is intended for the following audience: prospective and existing demonstration CCBHCs, individuals that works within those organizations, independent state CCBHC initiated staff and members, and CCBHCE grantees as it pertains to PDI and IA grantees, and also SAMHSA GPOs. So with that, I will turn it over to Peggy O'Brien to begin today's presentation and discussion.
Thank you, Clement, and thank you to the National Council as well for hosting this for us. It's much appreciated. Good afternoon, everybody, and thank you for your interest in this webinar. I'm really glad that so many people are here. Today, I'm going to address 3 of the clinic collected required measures. These are the time to services, our I-SERV, which addresses access, screening for social drivers of health, our SDOH, which addresses screening for our assessment of need. And the third is the measure of unhealthy alcohol use, screening and brief counseling, our ASC. which addresses both assessing need and response to that assessment. I wanted to also let you know that we will have time for questions at the end. We have an hour and a half for this webinar. However, after I address each of these measures in turn, I will stop and see if there's at least one question related to the measure in the chat or in the Q&A, I believe is where they want you to put it. So please, when you are putting questions in there, please identify the measure that you are asking about up front. That will be very helpful for us. Also, on the last slide, and the slides will be provided, I believe, according to the chat, our questions and Q&As so far. There is an email where your questions can be sent. So if you have questions about specific measures, the resource mailbox that you often send them to is not the one to send them to. Please send them to the submission mailbox, and that's on the last slide. So you'll be able to see that. Now, if I can just get there we go. Whoops. All right. Okay. I'm going to see how well I can do this today. So we're going to start with I-SERV first. And so we're going to begin with a poll. For those of you who are representing either CCBHCs or prospective CCBHCs, so clinics. Our clinic is prepared at this time, I'm talking about right now, to track requests for service and actual time to delivery. Please select one of the following responses: yes, no, partly, and I do not know. So I'm seeing responses come up at the bottom of my screen. Will we have it? There we go. So we'll give it time for the poll to catch up. How are we doing with the poll?
Yeah, we still have a few responses coming in.
Okay.
Let's give it about maybe another 10 seconds or so.
All right.
All right, so I'm gonna go ahead and publish it.
Okay. So 50% are yes, about 5% are no, 33 are part of the way there, and 11% responded that they weren't sure or didn't know. Great. Thank you. That's very helpful to know that there's so many people that are already on the way. Okay, so the I-SERV measure calculates the average time for clients to access 3 different types of services at behavioral health clinics that report the measure. And these are average time until provision of initial evaluation, initial clinical services, and crisis services. The measure is important in part because the certification criteria for CCBHCs include ones related to time to access for certain services. More importantly, however, we know that a substantial percentage of individuals in the United States who have mental health disorders or substance use disorders or both do not receive needed treatment. and some part of that is due to lack of access. So for your quality improvement purposes, this measure promotes the implementation of a systematic tracking of requests for and receipt of CCBHC services, helps you determine your access needs and your ability to deliver timely services, and allows you to alter your practices as needed to expedite services that are required for your clients. It is also used in evaluation of the CCBHC model and has potential use for quality bonus programs under the PPS for those of you that are in the Medicaid demonstration. Sorry about my cursor. I'll try to keep it off the screen. And just also so you know, at the end of the slide deck, it's like I think the third from the end or the second, there's a list of references. So if you look on this slide and you see the citation in the first bullet to SAMHSA 2022A, you'll find the actual reference and the link for all of those kinds of materials on one of the last slides. So the data source for I-SERV is referred to as medical records, but more specifically, it would be your digital scheduling system. Also, for each of these measures, all three of them, I will talk about the measurement period, which is the time period for which certain data must be available, and that's distinct from the measurement year. The first measurement year for which I-SERV applies is calendar year or measurement year 2025. The data, however, that you will use for the 2025 measurement year will, in some cases, require data from 2024. So I'm going to go into all of that. The data for the denominator is for the average of the times to initial evaluation and initial clinical services is the first 11 months of the measurement year. So let's just say 2025, the first 11 months, and 6 months prior in 2024. For the crisis service average, the date for the denominator is the measurement year plus 1 day before and excluding the final day of the measurement year. So bear with me on this. I'm hoping that things will become clear as we go through the actual submeasures. And for all three of the submeasures, the numerator, the measurement period is the measurement year. Okay, so I'm going to break this down by submeasure. I will start with submeasure 1, which is the average time to initial evaluation. So for those of you who missed the first spring webinar, I went into a fair amount of detail about what constitutes a quality measure. I-SERV is a little different, and it really is just an average where you divide the total number of days until service for eligible clients, that's the numerator, by the number of eligible clients, which is the denominator. So to get the denominator for the first measure, which is of time to initial evaluation, you provide a count of all clients in the eligible populations. So that is all new clients who contacted the CCBHC seeking CCBH services during the first 11 months of the measurement year. New clients are those who were not served by the CCBHC in the past 6 months before they were seen at the point in 2025. They have to be 12 or older by the end of 2025 to be counted in the eligible population and the denominator, and then you will exclude those who never received an initial evaluation. There's information about stratification on the bottom of the slide, and I'm going to talk in more detail about stratification of the measures at the end of this presentation. But for I-SERV, the stratification is by age, payer, race, and ethnicity. And one last point here for these slides, I've tried to bold areas where you need to make sure you have data. So you need to be able to identify who is new in the past 6 months, their age, their payer, race and ethnicity, and if they ended up never receiving an initial evaluation. And I also, on each of these slides about denominator and numerator, have balloons that include reminders about the measurement period. The numerator for this is the total number of days from first contact to initial evaluation for everybody in the denominator. As you can see at the bottom of the slide, the technical specifications will tell you how to count days after the last day of the measurement year. Additionally, though not on the slide, the specifications also tell you what first contact means. So this is my way of saying you cannot rely on these slides as your exclusive guide to how to calculate these measures. You do have to look at the specs closely. Thank you. So I have a practice example here, and I'll walk through this one in fair detail, not all of them quite so much. So for the denominator, in the CCBHC in, let's say, 2025, had 2,000 new clients requesting CCBHC services during the measurement year. And of those, 500 requested service during the last month of 2025, so you remove them. You remove the 150 who were 11 years or younger on the last day of the measurement year. You remove 125 who never received an initial evaluation, and you come up with a denominator of 1,225. And then on the right side of the slide, the numerator is just the total number of days between the request for services and initial evaluation for all of the clients that are in the denominator. So 9,889. And then you see here the calculation. You divide the numerator by the denominator and you'll get 8. This means it was an average of 8 days until initial evaluation at this CCBHC during the measurement year. So I'm going to move on to the second submeasure under I-SERV, time to initial clinical services. And this is very similar to the time to initial evaluation. The denominator is exactly the same as the denominator for number 1, time to initial evaluation, but the exclusion is of those who never receive a clinical service rather than never receiving the initial evaluation. And the numerator is similar to that in number 1, but it is the total number of days from until the initial clinical service from first contact for everybody who's in the denominator for number 2. Okay, so similarly to number 1, we have a practice example for submeasure 2, where you are essentially substituting initial clinical services in place of initial evaluation. Again, the denominator is number of new clients requesting CCBHC services who didn't request it in the last month of the measurement year, who are 12 or older on the last day of the measurement year, excluding those who never received an initial clinical service. And the numerator is the total number of days for the clients in the denominator between request and receipt of those clinical services. So in this case, when you do the calculation, you end up with 6.23. This means it's an average of 6 days until initial clinical services at the CCBHC during this measurement year. Okay, so I'm going to move on to submeasure 3, time to crisis services. So let me start by calling your attention to the note at the bottom of the slide where we include the definition of a new crisis episode from the text specs. A new crisis episode begins when the crisis service provider, whether it's a CCBHC or its crisis DCO, receives a contact related to needed crisis services for a client for the first time in 24 hours. So for this measure, the denominator is the number of all clients who contacted the CCBHC or its crisis DCO seeking CCBHC crisis services for a new crisis episode during the measurement year and who were ages 12 or older at the end of the measurement year. And the numerator is the total number of hours from the crisis episode contact to the related provision of a crisis service for all members of the denominator. Again, we have a practice example, which I'll walk through in detail as I did for the first one.
Oh.
So calculation of the denominator, which is 372 people, begins with the number of clients, excuse me, seeking crisis services from the CCBHC or its crisis DCO, in this case, 600 people. You subtract the 100 who had requested crisis services already during the prior 24 hours. You subtract 120 who were not old enough to be counted. They were under 12 at the end of the measurement year. And you subtract 8 who never received a crisis service. So you have a total number of clients that are eligible in the denominator of 372. And then you take the total number of hours between crisis episode contact and the related provision of crisis services for all of those clients in the denominator. In this case, it's a total of 1,296 hours. And so if you do the calculation, you will end up with 3.48, which is rounded to 3 hours. So it's an average of 3 hours until receipt of crisis services at the CCBHC during this measurement year. Okay, so I know that's all fairly tedious, and I hope you're all awake. I see questions coming in, so somebody's awake. But this slide is really important, so please do pay close attention to this one. This covers the things that your CCBHC needs to do in 2024 to prepare for calculation of the measure covering measurement year 2025. First of all, your CCBHC should prepare to and begin using a way to identify clients served no later than July 1st, 2024. This lets you look back once you're in 2025 to see if anyone is already an established client instead of a new client. Second, you should begin preparation for being able to track the date that services are requested, and in the case of crisis services, that would be date and time, as well as the date that the initial evaluation and initial clinical services are provided, the date and time of crisis services. And you should plan to implement this ability to track no later than December 15th, 2024, and that's being very generous, I'd say, because the sooner you can get it implemented, the sooner you will know that it's working as you need it to when 2025 comes around. And third, and very important, in 2024, you should start training staff regarding the documentation needed to record the date and time of receipt of request and receipt of services. So what I'm going to do here is I'm going to pause. I know there are a lot of questions and some of them may be identical, but what I'm going to do is see if Shweta, if there is a question that kind of rises to the top or was one of the first ones.
Yeah.
And you can share it and I'll try and answer it here and now.
Sure. Sure, Peggy. So when we were going over the numerator slide, where we said the numerator is the total number of days from first contact to initial eval for all members of the denominator, someone asked if the number of days is related to business days or calendar days.
That is actually answered in the specification, and in the specification, if it's not actually in the specification itself, we have what I've called frequently asked questions section. And that is a question that should be in that frequently asked questions section or in the actual specification. And I also think that it is actually specified in the certification criteria what you're using as a count of time. So, but if it's unclear, I will provide a better answer. And I do see a question here. I'm sorry, Shweta, I just want to, somebody just asked how you access the specification document. I put a link in the chat. It's up at the very top of the chat, with the preliminary version of the specifications. The preliminary version includes all the introductory material in the appendices, as well as all of the measures that are not NCQA stewarded. That those will be joining as soon as possible. So sorry, Shweta.
Oh, no worries.
I think I have time for another
One more?
I-SERV. Yeah.
Perfect. Okay. Someone's asking how we define clinical services. And whether any of the required 9 services, is it any of the 9 required services, or is it just outpatient behavioral health treatment?
The way I would define it is those that are envisioned by the CCBHC certification criteria program requirement 4 for scope of services. And I can clarify that if clarification is needed, but that is the way that I would approach it. So there are things in there beyond behavioral health services, including the basic screening and monitoring. But most people are going to be coming into you unless you're an FQHC for behavioral health services. Shweta, I think we can handle one more question on I-SERV.
Sure. How do we define new crisis episode?
Okay, that also is in the specifications, but it really is an episode that is the first contact for crisis services where there hasn't been one in the prior 24 hours. But it is clearly laid out in the specifications. All right, I'm going to move on to the screening measure. I have to make sure I get through all 3 of these measures today, plus the couple of miscellaneous things at the end, and then we will answer questions again on I-SERV if there are lingering questions, which I know that there are. So I'll get back to those. Okay, so this is the next measure is screening for social drivers of health, or SDOH, and this is much easier to calculate than the one that I just went over. So again, we have a poll that asks if your clinic, again, so this is for those representing clinics, is prepared right now at this moment to screen for social determinants or drivers of health. And please select one of the responses here. Yes, we are ready to screen right now. Or yes, we are ready to screen and refer to services at this point. No, we are not ready at this point. We're partly ready, or I do not know. And please enter your answers in the poll so they can be counted.
Or Peggy, we'll give it a few more seconds here and then I can go ahead and close this.
Okay.
All right, it looks like responses are starting to slow down. So go ahead and end and share.
Thank you. Okay. Wow. So Yes, and this measure, of course, doesn't go into effect until calendar year 2025. So this is really great to see. 22% are ready to screen. 23% are ready to screen and refer for services. 13% are not quite there yet. 28% are part of the way there, and 15% of the people weren't sure. So that's really good. It's if you're not ready right now, that's why we're doing this, so that you know what you need to do in order to get ready, and you have a fair amount of time. So let me go on to the next. Okay. All right. So the SDOH measure calculates the percentage of clients 18 years and older who are screened for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. And the SDOH measure is based on one of the CMS MIPS quality measures, and the number is there at the bottom of the screen. So I know I'm not telling anybody anything that they don't already know here, but just to be sure, we know that socioeconomic, environmental, and behavioral factors, also known as drivers of health, can have a substantial effect on health conditions and outcomes of treatment. So that is why it's a very important screen that needs to be done to determine what kinds of social needs your clients may have. This measure has multiple uses for your CCBHC quality improvement activities, including requiring that you implement basic SDOH screening into the services that you provide. It provides a way to determine what your clients' social support needs are, social service needs are, and it provides a basis for referral and case management supports. It also may be used for evaluation of the CCBHC model and may be used for quality bonus payments within the PPS for those who are demonstration clinics. So the source of data for the SDOH measure is electronic health records. And the measurement period, the time for which data is required for both the numerator and the denominator, is the entire measurement year. So the first one in your case would be calendar year 2025. The denominator for SDOH is all eligible clients who receive at least one CCBHC service identified by the CPT codes that are included in the technical specification during the measurement year, and who are 18 years of age or older on the date of service. This measure is stratified by payer, race, and ethnicity. And again, I'll get into more detail on those later in the webinar. The numerator is for all of those clients in the denominator, those who were screened for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety, using a standardized screening instrument at least once per measurement year. So the documentation that you need is that the standardized screening happened or didn't happen. And that would be identified in your electronic health records with the code that's in the technical specifications or an equivalent information source. So, oops, let me go back. Oops, okay. All right, so the practice example I'll go through in detail here. This begins with 2,500 people at the CCBHC receiving a service during the measurement year. And out of those, 2,000 received a service that was one of the appropriate encounter codes that's in the specs. And of those, 1,500 were 18 years or older at the date of service. So that gives you the denominator. To get the numerator, you take the 1,500 people who are in the denominator. You find that 1,000 were screened during the measurement year using an appropriate standardized screener, and 500 were not, or maybe they were, but it wasn't documented. That leaves you with a numerator of 1,000, and you divide 1,000 by 1,500, you get 0.67, so that 67% of the eligible population were screened during the measurement year at least once using a standard screener of SDOH. Okay. So I have shared a version of this slide a couple of times in the earlier webinars. And this shows 5 examples of standardized screening tools that are identified in the measure as being appropriate. As the slide says, these are examples. So if you are using a different standardized SDOH screening tool that covers the 5 social determinants, that also may be used. Okay, so this is the slide that will kind of give you guidance on what you need to do during the next year. Directly related to satisfying the measure, you need to identify the standardized SDOH screening tool you'll be using and determine where, when, and how in the clinic workflow screening will be implemented and documented. Prepare documentation systems needed to capture whether screening has occurred, and train your staff regarding screening and documentation. Also very important is the next step after you have done all that. It's not part of this measure, but it is what should happen if you get a screen result that indicates need. And that is to be prepared to provide needed referrals and case management based on the findings from the screening. Okay, I am going to pause and see if Shweta has questions that rise to the top in the chat. I'll try to answer them.
Someone says that they already screened for interpersonal safety in the comprehensive assessment. So they're asking if they should ask again on the SDOH approved screen.
I don't believe in requiring people to do duplicative work. I think that as long as you are asking questions that are valid questions to get the information, and you have a way to document that it's being asked, and you are able to document the results for yourself and for your work with the person, I think that is what is important.
The next question is if we have any recommendations or requirements on using the specified SDOH tool.
All I can say really is that the measure requires that you do it at least once a year for each client. It's specific to those 18 and older. And obviously you'd probably, in most cases, be asking parents if it were younger anyway. But also that the five screening instruments that I listed on that slide, they're included also in the technical specifications, along with links to where to find them. Our 5 recognized SDOH standardized screening tools that are often used. Like I said, you do not have to use one of those, but you should be using a standardized screening tool. And one more question, Shweta.
Yeah, and along the same lines, someone's asking if DLA20 is considered as one of the approved standardized screening tools.
Let me look. It is not one of the 5 recommended ones. If it is a tool that asks the needed questions and is standardized, then I would think that it would qualify. But I'm not familiar with it, so I can't weigh in on that. Okay. All right. Thank you, Shweta, for getting those questions out. I am going to move on. I want to make sure we get finished. Okay. The final measure that I'm going to cover today is the unhealthy alcohol use screening and brief counseling, or ASC. So again, we have another poll. You should be pretty good at this by now. At this point, our clinic is prepared to systematically screen for problematic alcohol use and provide follow-up services if needed. Yes, no, partly, or I don't know.
We'll give it a few more seconds.
Wow. Okay, this is really good. Okay, so 73% of you said yes, you were prepared to systematically screen for problematic alcohol use and provide follow-up services. 2% said no, 14 partly, and 12% I don't know. This is one of the measures that was around it that is currently in place from the original set. I mean, it's been updated with the new specs, but that is that's a good percentage there. Thank you. Okay, so as a reminder, the preliminary version of the tech specs, which I did put a link to in the chat, and which you can access on our website, at this point are limited to the non-NCQA measures. The ASC measure is one of those that's not included, but which will be. And so what I am going to do after I am through with this, at the end, I'm going to put in the chat directions for you to access on the CMS website, the ASC measure. We can't put it into our spec sheet because we're still working with NCQA, but it is publicly available. So I'm going to put that in at the end. In the meantime, I will talk about it. The ASC measure calculates the percentage of clients who are 18 years or older who are screened for unhealthy alcohol use using a systematic screening method at least once during the last 12 months, and who receive brief counseling if they are identified as an unhealthy alcohol user. There are 3 submeasures. The first is just simply, are they screened? The second is there brief counseling provided if needed? And 3, it combines screening and brief counseling. And I will explain why there are 3, and I will tell you if you really have to do all 3. So when I get to that. Okay, so why is routine alcohol screening important? Alcohol use disorder is the most common substance use disorder in the United States, and it also commonly co-occurs with other mental health and other substance use disorders. So in other words, the population that will comprise much of the clientele in the CCBHC clinics. So for quality improvement purposes, this measure requires you to implement systematic screening for problematic alcohol use into the services that you provide. It helps you determine your client's needs regarding alcohol use, problematic alcohol use, and it requires you to provide brief counseling responsive to the screening results. It also may be used in evaluation of the CCBHC model and may be used within quality bonus programs if you're a demonstration CCBHC. The data source for this, again, would be your electronic health records. and the measurement period, or the time for which data must cover, for the denominator is the measurement year. So we're 2025. For the numerator, it is the measurement period is the measurement year and the prior year. I'm hearing some noise. I'm not sure if everybody's muted. The numerator, like I think I said this, the measurement period is the measurement year and the prior year. So that would be for the calendar year 2025, it is 2024 plus 2025. And I'll talk about how to approach that. So the first submeasure is just of screening. For the submeasure of screening only, the denominator includes all clients receiving at least one CCBHC preventive service, which is identified by a list of codes in the tech specs, or 2 non-preventive encounters also listed in the tech specs, who are 18 years or older on the date of service during the measurement year, and excluding clients who meet specific requirements related to dementia, hospice use, or existing alcohol use disorder diagnosis. And those are all laid out in the tech specs. This measure is stratified by payer, race, and ethnicity. The numerator for submeasure 1 related to screening takes all the clients in the denominator and then asks who was screened using a systematic screening method. The documentation required, however, is if the screening did or did not happen, and if it did, whether it was positive or negative for problematic alcohol use. So the practice example here for the denominator begins with 2,500 people receiving a CCBHC service during the measurement year, with 2,000 of those services being one of the appropriate encounter codes. Out of those, 1,500 were 18 or older at the date of service. And then you exclude you were left with 1,200 because there were 300 that met the criteria for either dementia, hospice use, or existing alcohol use disorder diagnosis. So you have a denominator of 1,200 people. And then the numerator involves looking at those 1,200 people that are in the denominator, the number who screened positive using a standardized screener, which is 250, or negative using the standardized screener, which is 400, for problematic alcohol use at or in the 12 months before the denominator visit or encounter. So if you do the calculation for this, dividing the numerator by the denominator, 54% of the people who were eligible in this CCBHC were screened for the measure for that measurement year. Okay, this slide provides you with information on the systematic methods that the measure requires you to use. 3 are identified, and you must use one of these to satisfy the numerator for screening. The audit screening instrument with the score identified here on the slide, and a link to where you can access it. The audit C screening instrument with the score identified on the slide and a link to where you can access it. Or a single question screening. How many times in the past year have you had 5 for men or 4 for women and any adult older than 65 years or more drinks in a day? And a response to that. So the second measure is just, was there brief counseling if warranted? For the submeasure of brief counseling only, the denominator includes all the clients identified for submeasure 1's denominator, with the addition of the boxed text on the slide. So once you have the basic use of services, age, and exclusions from submeasure 1, you then further limit the denominator to those identified as an unhealthy alcohol user when screened for unhealthy alcohol use using a systematic screening method in the numerator of submeasure 1. And the numerator for submeasure 2 of brief counseling takes all the clients in this denominator that we just talked about on the prior slide and asks who out of those received brief counseling during the measurement year or in the 12 months before. The documentation that is required is if the counseling did or did not happen. And so we have another practice example with the same general numbers. For the denominator, we again began with 2,500 people receiving a CCBHC service during the measurement year, with 2,000 of those being a service with one of the appropriate encounter codes. Of those, 1,500 were 18 or older, with 1,200 remaining after exclusion due to dementia, hospice use, or existing AUD diagnosis. And then we look at how many of those screened positive on the alcohol screener. That is 250 in the denominator. Okay. So then the numerator involves looking at the 250 in the denominator, and out of those, 150 who had screened positive for problematic alcohol use, 150 received brief counseling. So that is the numerator. And doing the math, you end up with 60% rate of those who tested positive for problematic alcohol use receiving brief screening. Okay, so this slide includes the definition of brief counseling that is included in the measure. For purposes of the ASC measure, brief counseling for unhealthy alcohol use refers to one or more counseling sessions, a minimum of 5 to 15 minutes, which may include feedback on alcohol use and harms, identification of high-risk situations for drinking and coping strategies, increased motivation, and the development of a personal plan to reduce drinking. Okay, so I am going to move on to submeasure 3, which is screening and brief counseling. So this is where some of you will be excused. Providers are required to use only submeasures 1 and 2 unless you were reporting this measure, the ASC measure, as part of the CMS MIPS before 2017. Submeasure 3 is optional for everybody else. So the denominator here is the same as it was for submeasure 1. In other words, you're looking at the population for which screening is required. And the numerator for submeasure 3 takes all the clients in the denominator and then asks who in the last 12 months was screened using a systematic screening method, and if positive, received brief counseling. The documentation required is if the screening did or didn't happen, if it did, whether it was positive or negative, and if positive, whether brief screening occurred. All right, so I'll walk through this one. For those of you that do have to do it, I'm kind of curious how many people will, but let's start. So you're starting with 2,500 people receiving CCBHC services in the measurement year. And of those, 2,000 of the encounters were within the appropriate encounter codes. 18 or older, 1,500. And that leaves 1,200 after you take out those who met the criteria for dementia, hospice use, or existing alcohol use disorder. So you have 1,200 in the denominator. You take that 1,200 in the denominator, 250 screen positive, 150 screen positive and received brief counseling, 300 screen negative, and 650 were not screened at all. So the actual numerator is 450. So it's those who screened positive and received brief counseling and those who screened negative, for a total of 450. And then you do the calculation, and the CCBHC had a rate of 0.38 or 38% receiving appropriate screening and brief counseling as needed. Okay. Now, this slide includes some additional resources on SBIRT, or screening, brief intervention, and referral to treatment for alcohol use, and is useful probably for all three measures, all three submeasures rather. All right. Here is what is needed for the ASC measure, which you should be doing in 2024 to be ready for 2025. You should begin preparation for and using one of the three identified systematic screening methods, and if needed, brief counseling. You should determine where, when, and how in the clinic workflow screening, and if needed, brief counseling will be implemented and documented. Prepare documentation systems needed to capture whether screening and, if needed, brief counseling has occurred. Train staff regarding screening, brief counseling, and documentation. Begin collecting data for the numerator in 2024. And determine if you fall into a category that does not need to report submeasure 3, and if so, whether you will calculate it anyway. And then there are also a couple of very important things beyond that, beyond what the measure requires. Your clinic should prepare to provide further assessment and treatment when problematic alcohol use is revealed by screening, and additional services beyond brief counseling are needed. And prepare to more appropriately screen special populations such as youth, pregnant people, or those taking medications where alcohol use is particularly counterindicated. Those are examples. You may find that obviously the cut points on the screening are going to be quite different for pregnant people. You may find that there are tools for youth that you want to use, and this measure is ages 18 and up, so you're going to want to use a youth-specific measure for youth. So just pay attention to who you're actually serving, and this measure does not substitute for your clinical judgment in terms of screening. Okay, before I move on to stratification, I'm going to go back. Okay, so now, Shweta, do we have a question here that I can respond to on
Yeah.
ASC? Good.
Sure. They say the ASC is not in the specifications manual, and how do we get those for new PDI grantees?
Yes. So the specifications manual that you have right now, the link that's in the chat and the version that is on our SAMHSA CCBHC website is a preliminary version that includes everything except the measures that are stewarded by NCQA. And we're still working with NCQA on those measures. However, they are measures that are already out there in the world. And so for the ASC measure, after I am finished here and before I sign off, I'm going to put in the chat instructions. Actually, it looks like the chat is very full, but I will put it in the Q&A. Yeah, let me do that. Let's see if I can do it without messing up the just bear with me. I've got it ready. I just need to cut it and paste it. Okay. I'm going to put it in the Q&A because the chat is so full that I fear you won't find it, I think. Let's see if I can do that. Nope. I think I'll have to put it in the chat. Yeah. All right. Okay, these are detailed instructions on how to access those specs. I went through and I go step by step what you have to do. So this should be able to get you there. But obviously you're only going to be measuring people that are clients in your CCBHC. So can Sweetheart Clement, can you let me know if that's visible to everybody in the chat at this point?
So I'm not seeing it, Peggy,
Okay.
and others too.
Okay, let me see if okay. Now can you see it?
Yes, now we see it.
Okay. All right.
Yeah.
I couldn't get to the bottom of it to press enter. So
Oh.
all right. So there's a very long set of instructions on how to access it. It includes the link. Okay. You can't copy the chat. Okay, so that's
Okay.
going to be an issue. Okay. We will figure out what to do with National Council to make sure that you get these instructions, okay? Okay, so yeah, take a screenshot of the chat then. And I'm going to close this so I don't have to look at all of that and get distracted. Okay. Okay. I'm going to give people a moment to try and figure out how to get that out of the chat so that you can use it. All right, Shweta, do you have another ASC question lined up for me?
Yeah, you might have touched on this on your on this slide, but someone's asking why are we sorry, wonder why screening starts at 18 years versus and older versus younger, and they recognize this is likely in the technical specification, and they're thinking that as a clinician, with awareness, just thinking as a clinician with awareness of how young individuals with problematic use start using alcohol early on. So
yeah, that's a very, very good question. And it's a question that's appropriate for almost any of the measures. The ASC measure is taken from an existing measure, and we're really not allowed to modify it, except to the extent that we're asking that you do it at the CCBHC level. We definitely recognize that problematic alcohol use is a concern for younger people as well, very definitely. And there are tools, instruments, screening instruments that are validated on younger ages. And we are not by any means discouraging you from screening adolescents or anybody younger than 18 years of age. We think it's very important. But the measure is as we find it, basically. And so that is how it is written, and that's what we're being asked. We're asking you to measure. We're asking you to measure this, but feel free and to screen as appropriate for other ages. Okay, I am going to move on at this point to a couple of other matters, and then we'll come back for more questions. Okay, I promised to talk about stratification. So each of the three measures I've talked about today do involve some stratification. So actual stratification of these measures may be by age, payer, race, or ethnicity. Only I-SERV calls for age stratification, and I-SERV measures access to services for those ages 12 and older. And we have stratified that into ages 12 to 17 years and 18 years and older. So I'll talk more about the reporting template later, but the specifications call for reporting the access the results of the measure for those that are 12 to 17, and then those that are 18 and older, and then in total. So in addition to that, for I-SERV and the other the other two measures, there is also stratification by payer, race, and ethnicity. So for payer, there are two categories that we're using now. There is going to be Medicaid only, so people who have only Medicaid paying for their services, versus other. And so other includes a lot of different kinds of funding sources, including people who are dually eligible for Medicare and Medicaid. Those go into other. Those who are being paid by Medicare, those who are might have private insurance, those who have no insurance whatsoever. All of those go into other. The categories for race, there are 7 categories that correspond to common CMS categories that you will see in Medicaid data. And these are listed here: white or Caucasian, Black or African American, American Indian or Alaska Native, Asian, Native Hawaiian or Pacific Islander, more than one race, or unknown. An unknown, and this is the same for ethnicity, unknown is anything that does not fit into the categories. So that could be somebody who does not want to answer, somebody who can't answer, somebody who comes up with an 8th category. So that's what an unknown is. It's everything that doesn't fit neatly into one of those other categories. Ethnicity is also based on CMS ethnicity categories. And so they are not Hispanic or Latino, Hispanic or Latino, or unknown. So there is more detailed information on all of this, and I especially urge you to pay attention to the payer information. It's included in the introductory materials in the text specs, and it is in those first chapters in the preliminary version of the text specs, to which you have a link. It also will be in the detailed instructions for the reporting templates. So this will allow you to meet the stratification requirements that are in the text specs and in the reporting template. Okay. Now I want to talk a little bit more about look back periods, because that's the most troubling, probably, part of all of this. I kind of address it in each measure, but I want to talk about it specifically now. Okay, look back periods can mean that you need data from prior to the measurement year. So if a measurement period calls for earlier data. Examples that we have seen today: assuming a measurement year of 2025 for I-SERV, you need the last 6 months of 2024 just to see if an individual is a new client, and you need the last day of 2024 to see if they're in an existing crisis episode. For ASC, you'll need all of 2024 just to see if your clients were already screened for problematic alcohol use in the 12 months prior to whatever their 2025 visit is. The same if they receive brief counseling during that 12 months prior. There is no look back period for SDOH. Okay, so with that, I'm going to turn it over to Shweta, and she will talk about upcoming webinars.
Thank you, Peggy. We can move to the next slide, please. I'll speak about some upcoming technical assistance for quality measures. So today we had our first of the 3-part series on guidance for clinic collected measures. We are going to have 2 more webinars where we will speak about other clinic collected measures, and they will be on Wednesday, November 1st, 2023, followed by the other webinar on Thursday, November 9th, 2023. Next slide, please. Okay. So either in November or December of 2023, we will have office hours to answer any questions you may have on clinic collected measures. In January and February of 2024, there are 2 state director meetings where state collected measures for CCBHC demonstrations will be discussed. And either in March or in February or March of 2024, we will hold a webinar on the reporting template and commonly asked questions on quality measures. And lastly, in March of 2024, we will hold office hours to answer your questions on state collected measures. And we hope that these technical assistance we hold for quality measures will prepare and support you for your reporting. And I think we're ready for questions, so we can move on to the next slide.
All
So
right.
yep. Would you like me?
Sure.
Awesome, thanks.
Yeah.
Would you like me to start reading out the rest of the questions?
I do want to add something. I'm actually going to go back to the prior slide just so, because I'm kind of keeping an eye on some of the questions that are coming into the, there we go. Oops, nope. There we go. I'm keeping an eye on some of the questions that are coming in. And so we have these very definite, some scheduled, some not scheduled yet. TA opportunities that are going to be coming up, including the office hours and the meetings. I'm cognizant that the January and February meetings are meetings that are for state directors and their staff for the state collected measures. However, all of the attendees on this webinar have an interest in understanding what those measures are, because they're about your clinics, and they will be measuring your clinics. So what I'm going to try to do is, after we have done the state collected measures, I'm going to see what I can add on here in terms of getting information out to you all, the clinics, about the measures that are state collected. So I want to make sure that you know that this is not everything that you're going to ever have a chance to learn about. Also, everything that we do is recorded, and you will have access to the slides, and you'll have access to the recordings. And I want to also remind you that in the spring, we did 3 webinars that were introductory in nature, that talk about timing of reporting and various other things. So I also refer anybody who hasn't seen those to go back to them if you want to learn more basics that you don't have yet, or if you need a refresher. And all of the recordings will be available to rewatch if necessary. So I'm going to stop with my my rambling there and let Shrita go ahead and ask questions.
Yeah, so just someone mentioned that the practical examples were really helpful, and they said thank you on that. Okay. And there are a number of questions, so my apologies if I'm skipping anyone's in order. But there's a question on the definition for a systematic screening method. Mm-hmm. If we had a definition for that.
We do not. And that kind of comes into play both for the alcohol screening and for the SDOH. A systematic screening tool or instrument is one that has been validated for whatever group of people it's being asked of, basically. And for the SDOH measures, we know that the 5 that are on that that are in the specs that are identified are systematic and validated and available for public use. For the alcohol screening, you don't have as much leeway with because the measure kind of requires you to use one of the 2 audits or the single question screener. So That's a long-winded answer to say that systematic screening is a tool or instrument for assessment or screening that has been validated in the audience to which it's being used and in the language it's being used, which is a lot to ask sometimes.
So the next question is, how should someone identify a request for services? Many times a person will call in for crisis and a staff responds immediately, but this goes into the same activity or note.
Yes, and there is in the I-SERV technical specification direction on how to determine that. I'm not going to paraphrase it because I'll get it wrong, but it is there. There are instructions in the technical specification for how you determine initial contact of new crisis episodes, new clients, various things like that. And let me also say, as I mentioned before, there are FAQs in the specs themselves based on the experience that we've had over the years with the prior specs. However, because what you have now is a preliminary version of the specs, when we are able to get the NCQA measures in, if as a result of these webinars, there are questions that come up that are not addressed in the specs, we will have the opportunity to get them in before the final version goes out. So that's why I'm happy that I'm actually able to be getting questions from you right now, because there may be things that haven't occurred to me or to others that need to go into the specs that will answer some of these questions.
There are a few questions on the use of acceptable screening tools. There are a few ones that folks have asked whether they're acceptable. Did you want me to read them, or do you have a general sense on how folks should approach this question?
I will respond separately for each of the two measures that involve screening. For SDOH, again, there are 5 that we know are fine. And if you have others that address the things that are covered, we just ask that they be systematic and that you follow the screening instrument as it's developed. For ASC, I know that many people, for instance, your EHRs may have some automatic alcohol screening in it, like the cage or some other screening. The cage is not suitable for everybody. It's been a long time since I thought hard about this, but if I recall correctly, it's not as suitable for women as it is for men, and it's not suitable for pregnant women. So just because something is a default in a off-the-shelf EHR doesn't mean it's the best that you might want to use. For purposes of meeting the quality measure for the ASC, you do need to use one of those 3 screenings. However, as I mentioned, there will be times when the cut points are not going to be appropriate. They're not going to be appropriate for pregnant people. Those screening instruments may not be appropriate for children or adolescents, and there are more appropriate ones. So you don't have as much leeway with the ASC as you do with the SDOH, but the reason is that you're being asked by the measure to do it, and that's what's being measured.
And there are some questions on billing codes, on what appropriate billing codes folks can use for screening. So if we have a general guidance on that.
Yes. So for both SDOH and the ASC measure, there are codes in the specs. And so if you if you can follow the directions I put in for the ASC, you will find those codes for that one. And in the tech specs that are online, that are in that you have a link to, there is a code that is created as part of that quality measure for receipt of screening or not. We do say generally in our specs that I know a lot of those codes are not used very consistently, and part of that is because people aren't used to it, and part of it is because they're not in and of themselves billable codes. So we kind of face reality in that way and recognize that there may be other sources of information that you have in your medical records, if you're not using those codes, that will allow you to capture the same information. That's all I ask, is that you be able to capture the same information. Has somebody been screened for the SDOH? Whether it's using the code that's in the specification or something else. How do you know that? As long as you know it, then you can calculate the measure.
So the next question is asking if there's a template for the PDI grantees to use to submit quality measures, and whether
Yes,
we have a link to that.
it is going through the final clearance processes at this point. It will be the PDI and the IA grantees will be using the same template that the demonstration clinics use. And in the list of webinars, let me go back here up. Okay. We have on here late February or March of 2024. We are hoping, really hoping, that it will be available and out by then. Whether it is or isn't, I'm going to have a webinar about it. But that will be available. And part of the reason that I talked about stratification today in fair amount of detail is that the stratifications have changed since the old reporting template was created. So I wanted everybody to be aware of that fact, so that we are asking for different categories of payer, for instance, than we did before. I'm trying to get this information out to you without yet having been able to give you the reporting template, but our objective is to get that out as soon as possible, and it will be available for all CCBHCs, whether you're only a discretionary grantee or whether you're only a demonstration clinic, or if you're both, you'll be using that.
We have a question on if someone's asking if we could repeat submeasure 3 and who it does not apply to.
For ASC probably is who you're
I
talking
believe so, yeah.
Okay,
There
let me-
isn't a,
yeah.
the name of the measure.
And this is also, this will be in the spec for this one. Okay, so submeasure 1 and 2 are the ones that are just screening and just brief counseling, and 3 combines it. So this is derived from one of the MIPS measures. It's a set of measures that CMS has. And prior to 2017, it was just submeasure 3 that was available. So it was this kind of combined complex measure. And so if any of the clinics on this call or any CCBHCs have been reporting MIPS before 2017, that's what you would have been reporting, and you would still be reporting it. If you don't fall into that category, if you haven't been reporting this measure for the past 6 or 7 odd years, then all you're required to do for this is submeasures 1 and 2, which separates it out into screening and brief counseling.
And for the ASC measure, is it yearly or every 2 years, the reporting?
It's yearly. And so let me see if I can do this, explain this look back period for that a little bit better off the top of my head. This may not work. So you have somebody who comes in to see you in 2025. At some point during 2025, that person is going to have an encounter with you, and you're going to need to screen them for problematic alcohol use. If they were already screened the year before, in the 12 months prior to the time they are seen in 2025, which is why you have this 12-month look back period into 2024, so you can determine if they were already screened and if you need to do it or not do it this year. That's what the look back period is for, and that's why you have the 2024 data in that measure. The same is true for brief counseling. If somebody was screened and received brief counseling in 2024, then they are counted as meeting the measure for 2025. So that is what is complicated about it. If you have screened, if you've done brief counseling when necessary, within the past 12 months, you meet the measure requirements. If you haven't, you need to do it in 2025. But so that's what's being measured, and that's what's being reported is you meet the numerator if it's done in 2025. You also would meet the numerator if you were screened within the 12 months prior to that visit in 2025. But it's one rate for 2025. That's the best I can do to explain it. But I'll try and put it in writing in a way that's a little bit easier to understand. I think we have, time has really flown. We have 5 minutes left. Let me see if there's anything else. I know we have a lot of questions, but I want to get to this last poll. So let me advance. Okay, so this is the last poll and the last thing I'm going to ask of you. In the last 90 minutes, I have learned a lot of new information, some useful new information, very little, not sure, or other. Okay, great. All right, so a total of almost 90% of you learned at least some new information, so I'm glad. And I do see comments about we need more time for questions, and I totally agree with you. And I'm seeing Naomi gets this question. Naomi, if you want to put it, or if somebody could put it back at the top of the chat, I'll try to answer it. The next one of these webinars is really going to be 2 measures. The final one is going to be just the optional measures. And I am going to have office hours. So let's see what this, Shweta, could you read the one?
Sure. Yeah. I also just added that question in the chat. It's a little long. If a client is in crisis and receives the appropriate crisis services, and this later leads to a request for clinical services, do we need to measure each request for services separately?
No. If that was the first, if they don't meet the requirement to be a new client, which they don't because they were there for crisis services, then that counts. The crisis services are part of the services that are included in the clinical services.
And they
Okay.
had a follow-up to that
Mhm.
asking that is a crisis request to crisis service and service request to initial evaluation, or since the crisis request happened first. That's all that would need to be measured and reported.
So if you had somebody coming in for a crisis service, you measure the time to crisis service. If they also were if that was the first time that you had seen them in the past 6 months, then you would also end up measuring time to initial evaluation and time to clinical services. Well, clinical services are the crisis services. So you would still want to measure time to initial evaluation. That would be in the hope that they would follow up with you and get additional services. Okay. My goal is that the questions get answered one way or another, and that the answers get shared with everybody equally. So I really apologize. I can't get to all of your questions, but I will get them answered. Okay. And so Clement, do you have anything else you want to say?
No, just to reinforce that this slide will be made available on the SAMHSA CCBSC website, and I think at the TTA Center we will be sharing a copy as well too, along with the recording. And that's all I have. So I mean, hopefully we see you all again in webinars number 2 and 3. And thank you once more for joining.
Thank you.